My evolution in thinking about the nerve as such a key and crucial structure in all these injuries really comes from having spent a lot of time dealing with post-traumatic reconstruction and revision surgery and having to deal with that. Patients that come in with, radial nerve palsies after humeral shaft fractures, median nerve injuries after distal radius fractures. If you don't prioritize the nerve at the time of the injury, then you're compromising the patient's ultimate neurologic outcome. And I think that if you talk to patients long-term in regards to their functional outcomes after a major trauma to the upper extremity, often they will discuss their lack of neurological function at the end of the day. So I think it's very important to address the nerve early and aggressively in order to maximize that patient's outcome. The nerve can see injury even if the nerve isn't cut. And so when we see zones of injury, whether it be from bony injury or from soft tissue injury, even without an injured nerve, it's important to remember that the nerve lives in the same home. Everything that affects and impacts that soft tissue in that area, that affects tendon gliding, that affects bony healing, and also affects the nerve. And so seeing these patients over and over again really made me begin to recognize that these patients need something more than what we're doing for their nerves at the time of the injury. If you become so honed in on the bone and fixing the bone and don't think about the other soft tissues in that area and have good soft tissue technique and good soft tissue handling, then you're going to really limit your patient's outcomes. One example of when I use nerve protection is in bony trauma, particularly around the humerus. The radial nerve, I don't like it to contact the plate, so I'll wrap the nerve in that location. The plate has to go up the shaft of the humerus, and I've circumferentially had to dissect out the radial nerve. Same with the distal humerus around the medial epicondyle, if a plate's in that area. I'll often anteriorly transpose the nerve and then wrap the nerve in that area. Again, in these traumatic sort of situations in which there's going to be significant ischemia due to swelling and edema, I really like to protect the nerve from those sort of environments. If the nerve isn't protected, it can become adherent to the metal, it can become adherent in that area, and that can create a point of tether around a mobile joint that can be often a source of nerve pain or nerve irritation or nerve damage. Using a protector in order to provide the nerve with a protected environment can help to prevent those adhesions that form around the nerve, because if you have to go back in and operate on those nerves, it becomes very difficult and the risk of nerve injury is very real, whether it be at the time of injury or later on as the patient heals and continues to recover. You really need to think about how the nerve is going to react to that zone of injury and protect the nerve in any way you can.